السلام عليكم. أنا سعيد جدا بتواجدي معاكم النهاردة، وشكرا للدعوة الكريمة من أستاذتنا الفاضلة الدكتورة لبنى والأخ العزيز الغالي دكتور صلاح صديقي ودفعتي. طبعا شرف عظيم ان انا اتكلم النهارده معاكم، وهنتكلم ربع ساعة بسرعة كده من غير ما اتعبكم. الحقيقة أنا بحب أتكلم بالإنجليزي، يعني ما بحبش أتكلم بالعربي في محاضرة بالطب. إحنا درسنا بالإنجليزي، I will try to talk in English عشان يبقى الأمور سهلة. So today I'm going to update you on what used to be called HRT or hormone replacement therapy. Now the terminology has changed to menopausal hormone therapy. So I am proud, despite being head of the department, I am a founding member of the EFRI. This is the Egyptian Foundation for Reproductive Medicine and Embryology, which is closely related to other endocrinal disciplines, reproductive endocrinology. And we are inviting you all to become members of the EFRI, and we have an annual event held around about June. So, of course, I am a strong advocate to my specialty. OBGYN is very special, as we all know. Observation, keeping the interests of the baby, generosity, inquisity, and, of course, nobleness is, again, part of our profession. And, of course, to sum up menopause hormonal therapy in just 15 minutes, it's a very difficult task. But as usual, I enjoy lecturing, and I will stick to the time. So simplicity is the name of the game, as Albert Einstein once said. Yesterday, we were taught what's called symptom-based medicine. Now we talk about evidence-based medicine, and very soon we'll be talking about intuition medicine for precision medicine. That is a very individualized medicine tailored to the benefits and goals of each and every patient. And individualization is a concept which is very strongly adopted when it comes to menopause hormonal therapy. So let's put this slide here talking about the WHI, a very famous randomized controlled study, and as you can see, it has included more than 100,000 women. But very unfortunately, it came up with conclusions that were very much misleading. So it came up with the conclusion that HRT did not prevent heart disease in postmenopausal women. But this turned out not to be true. And as you can see here, so that's why we made a U-turn in menopause hormone therapy, from widely being practiced in the 80s and 90s to criticism and decreased use in the years following that. So over the next years, extensive reanalysis and assessment of the WHI study turned out that it is methodologically and statistically flawed. And therefore, I would like to remind you that unanswered questions are far less dangerous than unquestioned answers. Such unquestioned answers were given by the WHI study and saying that HRT is not of any benefit. So this is why we had to make a U-turn and look into the group and in-between group statistical analysis, which turned out to be erroneous. Now, we talk about the timing hypothesis. Timing is all important when it comes to using menopausal hormonal therapy. The time of initiation affects relation to coronary risk. The estrogen may provide coronary benefit early in menopause rather than late menopause. The absolute risks of hormone therapy are much lower in early than late menopause. So it is appropriate for vasomotor control in early menopause, but it is not intended for chronic use. So timing is all important. When it comes to the timing, you start menopause hormonal treatment, and for how long? Excuse me. So step-by-step guide to hormone replacement. We have step 1, assessing if menopause hormonal treatment is right for that woman. Next, hormonal therapy options, when to start, how to follow up, and when to stop. So step 1 is to assess if menopause hormonal therapy is right for your patient. Now, what are the contraindications as regulated by the North American Menopause Society, the Menopause Association's current or post-suspected breast cancers, known or suspected estrogen-dependent malignant tumors, undiagnosed genital bleeding, previous VTE, and many other contraindications. So the main risks of HT use remain in the older age group above 60, those with a BMI over 30, insulin resistant, with the metabolic syndrome, or with family history of VTE. But to state that the presence of risk factors does not necessarily mean that hormonal therapy is not to be given. Step 2 is hormonal therapy options. We do have a lot of options nowadays, considering the types of remedies, phytoestrogens or natural estrogens, whether it be given by oral methods, by the parenteral methods, or transdermal patches, vaginal approach, or even carried out in an IUD, like the Mirena intrauterine system. So indeed, women are enjoying a great privilege of variability when it comes to hormonal options. But let's stress that estrogen replacement therapy should be given for all women without a uterus for fear of endometrial hyperplasia and endometrial cancers, whereas estrogen progesterone therapy are offered for women with an intact uterus. So when it comes to natural versus synthetic estrogens, the best studied synthetic estrogens are those contained in the pill or the contraceptive pill. But now we talk about a natural estrogen, carried esterified, which is an estradiol valerate. Of course, it's less potent than the synthetic ones. Micronization is a virtue, but it's a lot safer, and that's why it enjoyed more and more popularity in the last few years. It's also convenient for oral administration, and most importantly, it's safe for long-term use, even for up to 7 years, as studies have shown. So the do's and don'ts of administration, let's agree that the most appropriate method fits the woman's desires and acceptability. Well, the useful approach may be to start hormonal therapy at the lowest possible dose to provide relief, then to titrate up and down, or upgrade the dose, or downgrade the dose to the lowest effective dose, which is consistent with a woman's need. Step 3, when to start hormone therapy? Well, evaluating the risks for each candidate, we start with history, examination, and investigation. So history, of course, we talk about age, menstrual pattern, family history, lifestyle changes, and current medications. Moving on to examination and investigations, body mass index, weight, circumference, blood pressure, and blood tests if necessary, ultrasound, bone density, mammography if indicated, and bone densitometry, as Professor Osama is going to brief you shortly. So step 4, how are we going to follow up our patients? Well, as for the first 3 months should be a follow-up appointment after the initiation of MHT therapy in the first month to assess efficacy of treatment and to titrate the dose. Later on, it's carried out maybe at 3 monthly intervals or yearly thereafter. Adverse effects of hormone therapy include, as you may expect, bloating, breast tenderness, increased blood pressure, headaches, fluid retention, and some urinary problems. And step 5 is when to stop treatment. This is a very important question. Current users of hormone therapy can remain on treatment indefinitely, lifelong, that is to say, as long as they have no existent contraindications. Whereas regular monitoring of hormone therapy is advised with adjustments to type, dosage, and/or route of administration, and which are tailored to a patient's needs and circumstances. So, in short, MHT is a dominant therapeutic modality in climacteric medicine, a very recent terminology, which I much acknowledge because climacteric medicine, most women now spend a third of their lives past menopause, and this is why a subspecialty of medicine which is devoted to this group of women is called climacteric medicine. Of course, we have a male climacteric as well. The skill lies in the ability to choose the optimal MHT preparation for the given patient, follow the steps when starting from step 1 to 5, and the key is individualization using the minimal dose and early onset of therapy. It's more effective as long as you start early, indicated for the shortest possible time. So, ladies and gentlemen, are all secrets of MHT unraveled? Unfortunately, not. And let's be reminded that we have the secrets in our hands, not our tools. The tools are there to help the physician, surgeon, epidemiologist, or whoever to execute his work. So the magic is in the magician, not in the wand. And so to sum up, Chairman, ladies and gentlemen, menopause hormone therapy, now we talk about MHT rather than HRT. To sum up, it's to be given in the minimum dose, which provides relief for the lady. And you must take into consideration the human factors. Individualization is all important when it comes to the specifics of each patient and the requirements as far as quality of life. And last but not least, timing is all important, and this is an important aspect which has been recently raised, is that when to start treatment, how to monitor treatment, and for how long. Thank you very much.